Welcome everyone to the 2021 Virtual SMA Conference. This is Jessica from Cure SMA's Family Support Department, and we thank you all so much for joining us for the Rehabilitation of Speech and Swallowing Deficits in Children and Adults with SMA session today. We are so grateful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies for the incredible support of this year's Virtual SMA Conference. Please note that all lines are muted during this session other than for the speakers, but you can find the chat conversation tab located on the right side of your screen, and you can use this to ask questions throughout the presentation. And now I would like to introduce our speakers, Dr. Allison from Northeastern University and Dr. McGrattan from University of Minnesota. Dr. McGrattan?
Great. Well, thank you so much for that introduction. I am Caitlin McGrattan. I'm a clinical researcher at University of Minnesota Masonic Children's Hospital, and I specialize in swallowing disorders. I'm here with my colleague, Kristen Allison, who is a researcher at Northeastern University. She specializes in neurogenic speech deficits. And today we'll be talking about the evidence and theory guiding rehab of speech and swallowing in older children and adults with SMA. We're of course thankful for the support that's made this work possible. So as a brief outline before we dive in, what we'll be talking about today is starting with the anatomy and physiology for speech and swallowing. We'll then move on to the characteristics of speech and swallowing deficits in different types of SMA. And we'll conclude with what you're probably all here for, which is the evidence and theoretical foundations for speech and swallowing treatment in SMA. So let's start off and we'll talk about the foundation for both speech and swallowing processes, and that is anatomy and physiology of speech and swallowing.
Hi, I'm Kristen Allison, and I'm going to start off by orienting all of us just to the key structures that we use for speech and swallowing. Many of you may have wondered why speech-language pathologists also work on swallowing, and well, that's because a lot of the anatomy overlaps and with the same structures that are used for speech. So to start out at the top, we have the nose, which leads into a large chamber within the cranium called the nasal cavity. So under that, we have the mouth, and that leads into another large cavity called the oral cavity. And you see this big, large red structure here, that's the tongue. It's a highly complex organ composed of dynamic muscle layers that not only takes up a lot of the oral cavity there, but extends backwards into the throat where it's really important for swallowing. Also, the tongue is very important for forming and articulation of multiple different speech sounds. So it's very important for both speech and swallowing. If you follow the nasal and oral cavities to their ends, they merge in the throat, medically referred to as the pharynx. And if you follow this down, it'll lead you to the voice box, also called the larynx, and then down this tube called the trachea here and into the lungs. Now, of course, the lungs are a site of oxygen exchange. The way we fill up the lungs is through associated musculature. So the diaphragm here, which is this long, flat muscle that courses underneath the bottom of the lungs, is the primary muscle we use for breathing. So our lungs are a critical structure for survival, and so we're well designed with the rib cage surrounding them for protection. But of particular interest to us, there's a series of muscles between the ribs that serve to expand and contract the rib cage. These are called the intercostal muscles, and they help with breathing. So when we breathe in, the diaphragm and the intercostals work together to expand the chest cavity and draw air into the lungs. So now let's talk about how these structures are used for speech. So what we usually think about speech as just happening in the mouth, it actually involves all of the structures we were just discussing. So speech production is a bottom-up process, starting with breath support. So that diaphragm and those chest muscles are used to help us take a deep breath before we start to speak. Then when we start to speak, air is pushed up through the larynx or voice box, where there's vocal cords or vocal folds, which are pieces of tissues that come together and vibrate to produce sound that we hear as the pitch of someone's voice. This sound then travels up through the pharynx and into the oral and nasal cavity, and we then use our lips, jaw, tongue, and soft palate to shape this sound into recognizable speech sounds and words. So now let's talk about swallowing. So well, these same structures are used, but they must undergo a significant transformation in order to do so successfully. So if we zoom in on the head here, you can see, like we pointed out before, the voice box or larynx leading down to the trachea and the lungs on the anterior side here. But so posteriorly or towards the back, there's another tube called the esophagus, and that leads down to the stomach. So as we discussed earlier, there's the importance of lungs in supporting airflow through the larynx, up the pharynx and out the mouth for speech. For swallowing, what we need to do is really close off that voice box because we don't want food or lungs to go down there and into the lungs. That's what happens when food goes down the wrong way. So instead, all the muscles in the throat need to contract to close off the voice box and pull open the opening of the esophagus for food to enter. And then the internal muscles of the throat help squeeze and push everything down, similar to twisting out a towel. All right, next I'm going to pass it over to Caitlin, who's going to talk about characteristics of speech and swallowing deficits in SMA.
Thank you so much. Okay. So we all appreciate that, of course, with SMA, we have lower motor neuron degeneration, and that the way this can cause problems for speech and swallowing is really multifaceted. So as an overview, I'll be working off of the schematic throughout just to kind of highlight some of these problems. But the reason we have these deficits is because the underlying problems in the cranial nerve nuclei, deficits in accessory musculature, resulting in implications for craniofacial structures and respiratory musculature. And we'll dive into each of these. But to start out, let's just take a look at incidence of speech and swallowing deficits based on SMA. So if you look at the literature based on the different types of SMA we have here, this is just from one study, but you can see that we have really high incidence of swallowing problems. So 64% of patients with type 1 goes down to 34% for 2 and 3A, around the same, and then we get down to 4% for 3B. Likewise, if we look at speech, we see, again, very high rates where we have 73% of patients with type 1 reporting problems as characterized by repeating in noisy environments. And then we cut down to 43% for the type 2s and 3A, and then 19% down for 3B. So a lot of people are struggling with these problems. So let's take a look more at what are some of the problems that are reported by type. And I'm going to not list all of these percentages for you because you can see, but overall, some of the highest rates of impairment are reported for swallowing and biting and chewing. So people report fatigue when chewing. Choking is reported by choking more than 1 time per day, and food getting stuck in their throat. So these are all some of the most commonly observed problems. There's certainly more. These were just some of the heavy hitters that we see, but these are being reported in, type 1's 73+% of patients. And then as we get down to 2 and 3A, we're seeing it pretty consistently across the board, around 55% of patients. Now, when we look at speech manifestations, we can see some of the commonly reported deficits. So there are shortness of breath when talking has been reported in some patients. We see people being asked to repeat in a noisy environment, but also just being asked to repeat in general is commonly reported. And fatigue with talking. So just fatigue overall, this has actually been reported with chewing and swallowing as well. So what is the underlying source for all of these problems? Well, I gave you kind of an overview, so now let's dive in. So the first thing that we are talking about here is the deficits in the cranial nerve nuclei. Get out of this. Get out of my pointer. Here we go. So, pardon me. So what we see here is the image on the right is a cross-section of the brain and the brain stem, and you can see the different cranial nerves there. And what cranial nerves are essentially are the nerves that are controlling the muscles for speech and for swallowing that we talked about earlier. And these plug into the brainstem, and that's really where they're all getting controlled. So when we have degeneration, as we do in SMA, is we really have a degeneration at the source of where these cranial nerves plug into at the brainstem level, which means that the muscles can't be contracting for speech and swallowing the way we want them to. So this is clearly a problem for swallowing, and as I indicated, but as you can see here, we have different cranial nerves involved for various muscles for speech as well. So degeneration of any of these nuclei can result in weakness and difficulty moving the jaw, the lips, the cheek, the tongue, and even the vocal folds. So weakness in any of these muscle groups can affect the clarity of a person's speech. So next we have deficits that we see in the accessory musculature. And what I mean by that is the muscles of the head and neck that aren't directly innervating those muscles for speech and swallowing, but help support our heads. So as you can see in this image over here, we have the kind of head posture of a healthy adult, the way we would like it to be. And then we have over here is what we often see in SMA, where we have weakness of the neck muscles, and so we often, if we don't have great support for our heads with our chairs and things, is kind of this extended neck position. Now, this position is a really great position for CPR because it opens up the airway, as you can see here, compared to over here. But for swallowing, this is very harmful because it makes it so your airway is wide open, and in fact, for swallowing, you want to close your airway. So not only does it position your airway open for things to go in, but it's very, very hard to swallow with your muscles completely extended to the max of their stretchability. You want them in a nice neutral position where there's room to kind of contract easily. So it hurts in that regards too. There are more likely than not implications for speech in this as well, but there just hasn't been much research into it to date. So from a swallowing standpoint, I just want to take a step back and kind of link this with these clinical reports that we have, is that these reports of coughing and choking during feeds are largely a result of these impairments with the cranial nerve nuclei not having those muscles contract, and also weakness in these accessory muscles that are causing us so that we can't have ideal head position. So I'm going to go ahead and play this for you. This is a picture, this is a swallow study, which some of you may be familiar with. It's a moving x-ray, video x-ray of an individual eating and drinking. So in this is an individual just looking kind of forward towards these little gears. This is a lateral view, just like we had before. Here is their mouth. These are their teeth. This is the spine, and here is the throat. Behind it is the esophagus, and anterior is the airway. And again, anything black is what they're eating and drinking. So I'll go ahead and play this for you. And so this is how we ideally want swallowing to look. So it's very quick, it passes through the pharynx quickly and completely, and you don't see any really black left in the throat after the swallow is completed. Now in SMA, we have a very different picture. So this is a patient with SMA 1. So you can see that this infant is trying to swallow, but the opening of their esophagus isn't opening, so they can't get anything down there. And that's because all of these muscles in the throat that are responsible for pulling open that little segment and squeezing everything down, they're weak, they're not working. And so that is not only contributing to food being stuck in this little patient's throat, but also for things going into the airway, pulmonary, aspirating the material you may have heard of. And that's troublesome for respiratory health, can cause lots of problems there. Here is the same underlying concept of a problem in an older patient with SMA 2. And so again, you can see trying to swallow that food down, and it's certainly not as bad as we saw in that little baby, but still a lot of black sticking in the throat after the individual is done swallowing. And like I said in that normal image, after somebody is done swallowing, we shouldn't see anything black in the throat because you should have had it all passed down because the muscles squeezed it down that hard. So from a clinical standpoint, again, this is why these types of deficits are why we have these reports of food getting stuck in the throat, coughing and choking because they're aspirating, it's going into the lungs, and just fatigue. Because if you have to swallow, like these patients had to swallow about 5 to 7 times per thing they eat and drink, when you should only have to swallow one, you're doing 5 to 7 times the work per bite. Next, we have deficits in the craniofacial structures, and I want to start by saying that what is currently thought that many of these deficits are a result of weakness in the muscles that make it so that the mouth isn't moving and appropriate tension isn't being placed on structures. So specifically, what we see is that many patients with SMA have overjet, which is where you can see here the dentition isn't in alignment. They have reductions in lateral movement of their mandible, as well as reduced opening of the mouth to the point where it can often result in trouble with brushing teeth, oral hygiene in that standpoint, chewing food and biting food off. And what's thought is that, as with any other part of the body, I'll speak specifically to mouth opening, if you don't open your mouth to its full capacity over time, that joint is going to be restricted in movement because all of those tendons and ligaments and muscles just tighten up. And so over time, if you don't have treatment and your mouth isn't opening fully, then this is a problem. Cranial face, now from chewing, I indicated that clearly that these types of problems can cause issues with chewing hard foods, taking a bite of, say, an apple, things like that, and fatigue as well. But as far as speech, again, this likely have tremendous implications. As far as moving the jaw, if you can only move your jaw, if it's significantly reduced, clearly you probably have some speech implications there. If it's not tremendously reduced, it seems like we probably can adapt to that. But again, very little research in this area, so we'll talk about that more. So next, we will be talking about the evidence and theoretical foundations for speech and swallowing treatment in these areas. And before we dive into that, we wanted to just mention a couple things here. Within the field of rehabilitation, whether you're talking about speech pathology, physical therapy, occupational therapy, there's two general treatment approaches that a clinician one of two will be following, and sometimes both. First, you can have a restorative approach, and then secondary is a compensation. So if you're working on restoration, the goal is to improve the underlying impairment, right? So as far as, I think a tangible example is if you're thinking about, if you say you broke your leg, for example, and then you had to rehabilitate that leg, well, your goal is to get that leg stronger. So that's kind of the approach we're looking at, is strengthening in that perspective. So for speech and swallowing, the same types of things apply. So for this is looking at the physiologic support for speech and swallowing, strengthening and motor learning. So improving those neural networks, the neural control of how those muscles function, because it's not all about strength. You need the nervous system to control those muscles appropriately. On the other side of the spectrum, we have compensation. And the goal here is to maximize function and participation. So saying, okay, we know this is a problem. For example, when you break your leg, you're going to cast it, and we're going to give you some crutches to help you get around, with the goal of rehab once you take that cast off. So from this standpoint, from a speech and swallowing standpoint, what we often look at are behavioral strategies on how we can improve participation in the world and eating, environmental modifications such as modifying the types of foods you eat and the types of liquids you drink, and potentially, as we'll talk about more, is adaptive technology, such as you can see here, is maybe using technology to help communicate when you aren't able to independently of those items while you're continuing to work on independent production. So with that, I will hand it over.
All right, thank you, Caitlin. All right, so I'm going to be talking now a little bit about speech intervention for people with SMA. And before I get into talking about treatment, I just want to provide a little bit of information about some terminology for the speech deficits associated with SMA. So dysarthria is the name for the neurologically based speech disorder that results from impairments in strength, speed, range, tone, coordination, or accuracy of speech movements. Dysarthria affects both adults and children and can be due to a variety of different neurologic conditions that can either affect individuals from birth, for example, something like cerebral palsy or SMA1, and then it can also result from acquired neurological conditions like traumatic brain injury or ALS. As mentioned before, speech involves muscles and coordination of movements in many different parts of the body, including respiration, so for breath support, phonation, for producing voicing, resonance, and articulation. So dysarthria can affect all aspects of speech production, and all of we refer to these as different speech subsystems. In SMA, the primary deficit is weakness in these muscle groups, as Caitlin was discussing, due to degeneration of the spinal and cranial nerve nuclei. Therefore, the types of speech characteristics that we see are associated with weakness in these different muscle groups that are used for speech. So this weakness and difficulty moving these different muscle groups can result in speech characteristics that we hear in the speech of people with dysarthria. So characteristics that might be associated with weakness in the respiratory or phonatory system can include things like reduced breath support. People may have to take extra breaths, may only be able to produce 2 or 3 words or syllables on one breath, and need to take more frequent breaths when they're speaking. They may have a breathy or a hoarse vocal quality, and they may have reduced loudness overall, because that breath support is really important for establishing loudness of voicing. Sometimes people can have reduced intonation or prosody in their voice, and also difficulties with regulating pitch and loudness due to weakness in those respiratory and phonatory muscle groups. Another kind of feature that we may hear is hypernasality. So if you think of somebody with a really nasally vocal quality or nasally quality to their voice, that's what we talk about as hypernasality. And that can result from weakness in the soft palate, which is this red structure in the figure here that needs to move up and down to close off the nasal cavity for speech. So when it moves up, that helps make speech sound like it has a normal quality. If it's weak and does not close off that cavity, you get that hypernasal sounding speech. So weakness in the muscles of articulation, so weakness in the lips and tongue and jaw, can result in a slushy or slurred quality that we call imprecise articulation. Can also cause people to have a slow speaking rate and distortions of different speech sounds, including vowels and consonants. Altogether, all of these characteristics can make it difficult for other people to understand what a person with dysarthria is saying. So dysarthria exists on a severity continuum. So there are some people that just have very mild differences in how their speech sounds. It may be very highly understandable or intelligible, but their speech may have a mildly slurred or a slightly unnatural quality. For other people with dysarthria, intelligibility might be reduced, either slightly or severely for others. And that means it's hard for listeners to understand what the person is saying, particularly for people who don't know a person well. And at the profound end, people with dysarthria can have no understandable speech and may use vocalizations, but usually rely on other types of forms of communication. Reduced intelligibility, even when it's mild, can have really substantial negative impacts on social participation for people with dysarthria. So it can make it hard to have conversations. It can make it hard to make friends. It can limit independence and employment opportunities and have impacts on quality of life. So therefore, really maximizing intelligibility and functional communication is an important goal of speech therapy for people with dysarthria. So as we mentioned right at the beginning of this section, there's these 2 main approaches to intervention, this restoration, restorative approach, and then a compensatory approach. So for many people with dysarthria, a combination of both of these approaches is appropriate, and the balance of these approaches depends on the severity of the dysarthria and the degree to which you may expect improvement in these underlying motor function. So over on the left side of this slide, you can see for people with high speech intelligibility, but who have a noticeable speech disorder, the focus of treatment is usually to use compensatory strategies to improve the naturalness of a person's speech. And then also some different kinds of treatment approaches might be used to help with improving the underlying subsystem impairment if that's something that might be expected in the condition. So if there's a stable or improving course, not a degenerative condition. Okay, so in the middle here, people with mild to severely reduced speech intelligibility, the primary focus of treatment is to maximize intelligibility. So that can be done through a combination of these compensatory strategies. There's a lot of different behavioral strategies. I'll talk about some of these compensatory strategies in a minute that can help maximize intelligibility. And then also work on improving this underlying subsystem impairment if a person has an improving neurological course. If intelligibility is moderately to severely impaired, using some sort of alternative and augmentative communication to augment and help support intelligibility and functional communication is often appropriate as well. For those at the most severe end with no functional speech, establishing a comprehensive alternative and augmentative communication system is the first priority for treatment because we want to provide people with functional means for communication immediately. And then, if possible, we want to try to work on reestablishing support for speech. So now I'm going to talk about a few specific therapy approaches. So it's important to note that very, very little research has been done on these speech intervention approaches specifically for SMA. So most of what I'm going to discuss are treatment approaches that have evidence from other populations of speakers with dysarthria. Okay, so in terms of restorative approaches to treatment, there are a few different treatment approaches that have some preliminary evidence for their effectiveness in children and adolescents with dysarthria. Primarily, these have been studied in children with cerebral palsy. One approach, the subsystems approach, was developed by Lindsay Pennington and colleagues, and this is an approach that it's an intensive treatment that focuses first on breath support and maximizing breath support for speech production, and then working on improving all of the speech subsystem function in a hierarchical order. So starting with breath support and then working up to articulation. Lee Silverman voice treatment, also called LSVT, is an intensive therapy modality that has that focuses on increasing loudness. So this was originally developed for adults with Parkinson's disease, but in recent years has been applied to children with cerebral palsy and has been shown to improve intelligibility for children with dysarthria. So even though the focus of this intervention is specifically on increasing loudness, what we've learned is that by using this simple cue to increase loudness and working on it intensively, it can result in carryover improvements in articulation of speech sounds and intelligibility overall, not just loudness. There's also an approach called speech intelligibility treatment that was developed by Erica Levy and colleagues. And this focuses on both using this strong voice cue, which is similar to sort of the loudness approach, as well as a big mouth. So working on using those two cues together to maximize intelligibility. And this has also been shown to be effective in improving intelligibility for children with cerebral palsy. So the key ingredients that kind of are common to all of these approaches and make sense with what we know about dysarthria generally is that they focus on all speech subsystems. So intervention for speech with people with SMA should not only focus on articulation, but also needs to include intervention focused on all of the speech subsystems. We also know that intensity matters. So lots of practice is needed to actually change motor learning and the motor patterns used for speech. And then also the interventions need to focus on speech. So what we know is that muscles have to be conditioned during the task that needs improvement, not in general. So just strengthening exercises for the tongue would not be expected to result in improvements in speech without actually practicing it in the context of speech. I like to think of this as analogous to learning to play the piano. Learning to play the piano, like talking, is a highly skilled and coordinated skill that requires a lot of coordinated practice. And so just doing exercises to strengthen your finger muscles is not going to make you able to play the piano. The same thing applies to speech production. So you really need to practice moving the muscles during speech in order to make gains in that. Okay, so now I'm going to talk about some of the different compensatory approaches that can be used to improve speech intelligibility as well. So there's a variety of behavioral speech modification approaches that have been shown to be effective for improving intelligibility in both adults and children with dysarthria. For many people, slowing rate of speech can help improve intelligibility. Also, over-articulation or learning to exaggerate specific speech sounds and pausing can help boost intelligibility, as can using a loud voice. There are also different prosthetics that can be helpful. So for many people with SMA, a low volume and difficulty projecting voice is a common complaint. Therefore, personal voice amplification devices might be helpful, particularly in public spaces, work environments, places that have more background noise. There's a variety of different devices like this available. One is the Chatterbox device that's shown in the corner of this slide. But that's something that can be a helpful tool to boost intelligibility, particularly in different louder environments. Abdominal binders are supports that go around the abdomen and need to be kind of carefully used in conjunction with physical therapists and doctors, but they can provide additional trunk support that can support better breath support for speech for some people. And then there's other kinds of compensations that may also be effective. For example, pooling of saliva in the mouth can be a problem for people with SMA, and it can affect clarity of speech. So even cues as simple as remembering to swallow before speaking can help improve speech intelligibility. And also positioning can affect breath support and therefore speech intelligibility as well. So making sure when someone is going to speak that they're well positioned in their wheelchair or other kind of supported seating device where they can get their maximum breath support for speech is important. Augmentative and alternative communication, or AAC devices, are also a really important component of treatment for those with reduced speech intelligibility. AAC can either replace speech altogether for those with most severe dysarthria, or for many people, they can augment residual or existing verbal communication. For example, clarifying a message in a case when they're not understood, or providing extra cues about the topic to their communication partner. AAC devices might be needed more sometimes in interactions with unfamiliar listeners who may have more trouble understanding a person with dysarthria. And for this reason, AAC can be really helpful in maximizing independence for people who have reduced intelligibility. There are a variety of different types of AAC devices that vary in their technological complexity, from having no tech communication boards all the way up to high-tech devices that can be operated by eye gaze. And the different types of devices that are most appropriate for an individual just depend a lot on that individual person's presentation and needs and age, and can be worked out in conjunction with a speech-language pathologist or assistive technology specialist. Sometimes parents and providers can be hesitant to recommend AAC or think of it as kind of a last resort treatment. And so I'd like to alleviate some of the common misconceptions about AAC and advocate for the importance of starting AAC early. So first thing that we hear sometimes is that people are concerned, often parents are concerned, that AAC will stop their child from learning to talk. What we know from research is that actually AAC is really important for supporting language development, critical to communication in all modalities. So if you think about it, you know, a 2-year-old who's learning to combine words, a 3-year-old who could be putting 2 or 3 words together, if a child is not able to verbally speak yet, using an AAC device can help them learn to generate and formulate these longer sentences and learn different grammatical structures that is important to supporting their overall communication. It's also really important for reducing frustration. So even really young kids can get very frustrated when they're not understood. And so AAC can really help with reducing that frustration. We also know that if children gain the physical ability to talk, they will talk. And the reason for this is that talking is always more efficient than an AAC device. AAC is really important, valuable tool for many people, but it's very slow relative to verbal communication. And so if individuals are able to talk, they will do so. So AAC does not stop children from developing verbal speech. So collectively, the research really supports the benefit of introducing AAC early. Sometimes people also think that children may have to have a certain set of skills to use an AAC device. And what we know is that there are no age or cognitive prerequisites for benefiting from AAC. Instead, we just need to make sure that the system a person is using is individualized to that person's ability levels in order to be effective. And finally, sometimes people are concerned that AAC devices are too difficult to use or not really useful at home. And what we have learned about this is that, you know, the speech language pathologist's role, part of their role is to help provide training and support to families to use these devices and help their loved one use these devices across functional settings. And the more practice a person has using an AAC device across settings, the better their independence in the future. Sometimes we see kids who only have an AAC device at school, and so they use it at school, but then they never use it at home. And sometimes those kids graduate from high school and then don't have access to a functional communication device and have never really learned to generalize it across settings. So for that reason, it's really important to try to work on integrating it across environments as much as possible. So overall, the research supports early use of AAC for children with reduced intelligibility, whether or not they will need a device long term. So for some kids, it's a temporary need to help them boost their language development and functional communication. And for some people, it ends up being a long-term important communication modality. All right, now I'm going to turn it over to Caitlin to talk about swallowing treatment.
Thank you so much. Right. So the first thing I want to go through, in the same method, I'll be talking about a few different treatments. And I think for both of our presentations, we don't expect you to walk away from this being experts in this area, or it's more of what to bring back to your clinician or find a clinician who can help talk about some of these items with you. And we provide all of the references here so that if you have a clinician that isn't talking about this, you can actually bring up some of these references and chat with it together with them, or find somebody who is aware of this research. So for the first clinical problem with problems with biting things and chewing things, one treatment device that is great is the Therabite. So overall, the Therabite is done to stretch the jaw in controlled increments to improve mouth opening and biting and chewing, but also preventing it. So we know that preventing disorders is much easier than treating them across the board for most areas, in fact. But this is even more so with problems in jaw opening. So preventing that reduction in opening is really, really important. So what you do is, as you can see in this image, there's a picture of the Therabite here, and you put your mouth on these little mouthpieces, and then you can squeeze this down, and you can set how much that this will open up. And so you have really set increments and you just slowly go and increase this. This device is $580, so definitely not a super cheap thing. Some insurance will cover it. You typically, unfortunately, have to go back and forth a couple of times. That being said, I did want to point out there is research, not in SMA, but in another population, to show that if you essentially tape tongue depressors together and kind of use them as a lever, you can achieve the same results, which isn't surprising. It's just more burdensome in cleaning and everything else like that. So I should point out this has been studied in SMA type 2, but it was really a single subject study, so not a super strong study design. But in this, just so you're aware, the study looked at the effect of Therabite on a 32-year-old woman with SMA2. She had limited extremity movement, requiring power wheelchair with joystick, decreased mandibular opening, impaired her ability to eat meals off a spoon. She would have excessive spillage out the front of her mouth, so that was embarrassing for her. And her mouth opening was only 15 millimeters upon coming to the clinician, when it should be 50 for women. So very, very reduced. And she also had problems with fatigue and oral hygiene as a result of these deficits. So this patient was followed for 7 months, and she followed this treatment regimen that I put down. So she used the Therabite 10 seconds. So she held a stretch for 10 seconds. She repeated this 5 times in a row, and she did this 1 time per hour, which is a lot. So this, the muscles of the face, the head and neck, they're very, very strong muscles, as well as all of those ligaments are tightly knit. So you really, really need to like dedicate time to do this on a treatment once you already have reductions. Now, preventing, I would postulate, is probably less intensive. But in this study, she did this, they followed her over 7 months, and they found a 33% improvement, and that she reported not only did this improve her mouth opening, but they found functional improvements too. So she was better able to chew and to brush her teeth. So, you know, this is great. Do we need to do it for 7 months for this outcome? We don't know. This is a single subject study, and, you know, clearly more studies are needed. But there's research in head and neck cancer and other populations showing that this is a good treatment option. Next one I wanted to talk to you about.
Rub the ball between your chin and the bottom of your neck. Squeeze the ball as hard as you can with your chin, and hold this position for 10 seconds.
Okay, so you got a sneak preview of this one. The next one I wanted to talk to you about is called the Chin Tuck Against Resistant device, also known as CTAR. This has not been studied in SMA, but it has been studied in healthy normals and patients' status post-stroke with good research behind it. And this is something that you might want to do potentially for concerns for choking with food and food sticking. I want to add that a clinician should be doing a swallow study prior to recommending any of these treatments, so we know what muscles we're targeting. But this is a common type of deficit we see in SMA. And overall, using this therapy and this device that I'll talk through, it's been found to help improve the opening of the esophagus and also help to improve the closure of the airway, which are 2 very commonly seen problems in SMA. So the way that this treatment works is you can either use this little device. Well, I'll play it. You can either use the device shown with this gentleman here, or you can use just a little ball, and I'll play this video and they talk you through how it's done.
Rub the ball between
so
your
you
chin
can see the ball,
and your neck. Squeeze the ball,
and the individual squeezes the ball down
as hard as you can with your chin,
and then they hold it for 10 seconds, and that's the key. So I have this outlined here. For treatment, you're going to press your chin down, compress the ball, hold for 10 seconds, and you're going to repeat this 3 times. That's the first phase of that exercise. And then in that same session, you'll then do more of a quick. So you're going to compress the ball and then relax, and compress and relax, compress and relax, so much faster pace. And you do that 30 times in a row. So this treatment has been found to be effective in stroke patients if it's done 5 to 6 times per week, once a day, over 6 weeks. Key things to know that your clinician should be aware of this, but if you have a trach, this is not recommended. It won't be a comfortable activity, not to mention that these devices could occlude the trach. You can buy this device. It's $170 last time I checked, which was just recently. You can also buy this ball. They accomplish the same thing. What you can also do is just get a ball that's approximately 12 centimeters in diameter that allows you to compress it, and you can accomplish the same thing with that. And then the last device that I want to talk about is called the IOPI device, and so that's pictured here. Overall, the IOPI device is aimed at improving tongue strength, lip strength, and potentially cheek strength. The most research in its use, however, is improving tongue strength, specifically for swallowing. I'll add again, as we spoke about before, of doing speech. Actually, talking is the best therapy for speech. So this is a little bulb, an air-filled bulb that you put into your mouth, and you push up against your hard palate and push it really, really hard, and it's going to compress and tell you how much pressure you applied. And so this strengthens your tongue. It can help improve bolus containment in your mouth so you don't choke, and it can help you so you can better move food around your mouth so you can chew it more thoroughly. So here again, I have the treatment regimen listed. You'll press the ball up and hold for 3 to 5 seconds at 60 to 80% of your max pressure. And you take that max pressure with your clinician on your first treatment. You know, just like if you're at the gym, you're going to measure that and you're going to work off of that to figure out how much weight you need to lift. Same thing applies for exercising your tongue. You'll repeat this 10 times per session, and you'll complete 3 days per week for 8 weeks. This was how it was proven to be effective in the studies. Again, you could increase that if you want and see as well. Now, this device is quite expensive. It's $1,500. Again, last I looked. This is something that, generally speaking, would be you would go to your therapist and use. You could potentially be the one to buy the bulb, which are about $10 each. But that's something that your therapist should have, or someone in your area should have. Not all therapists keep these on site, I would say. They also have a home version, though, that is cheaper. If I recall, it's about $750. And again, you can try to get this covered through insurance pending your insurance. I've had not great luck, but sometimes it does go through. So it's worth looking into. And then I want to talk just briefly about compensatory intervention. So again, all of these exercises I pointed out are for older children and adults because they require following directions. I will say I've used these in some very, very young children that are compliant, and we've just started to introduce this as part of the routine, which has been a very helpful strategy so that once they are old enough to be more compliant for these to actually be strengthening, that we can just get going on it. But generally speaking, these are for maybe I would say like 5 to 7 years old and up, and certainly for adults. From a compensatory intervention standpoint, though, we can always do a few things with a relatively quick fix for symptoms. So like I talked about before with the postural support, making sure that you're in a well-supported chair with a neck support that is keeping your head from being in an extended position. There's been research to show just having like a little head strap that kept a head neutral during eating was an effective strategy. So as you can see, that was studied in type 2 SMA. Other compensatory interventions are to modify your liquids or solids. So when you're modifying solids, typically you're modifying either the size and the texture of the solid, making it so it's not crunchy, something that's softer and easier to chew. Will make it so it requires less effort, less fatiguing, and less likeliness to choke from it. Also, using binding agents like gravies and things like that are helpful to keep everything cohesive and spilling from your throat. Like rice is generally speaking very difficult to eat unless you put with like a lot of gravy on it, or like a binding butter kind of thing. And then of course you can modify liquids. So you can thicken liquids. You can change how much liquid you put in your mouth at one time. That can be easier to swallow if there's less liquid. And I should elaborate, it's easier to swallow a thicker liquid if your primary problem is in closing your airway. I do want to point out though, is that it's important for you to talk to your clinician about these as it relates to your respiratory health, because we know that if you do a swallow study and you aspirate it and therefore are on thickened liquids, sure, that will prevent aspiration, but potentially, as long as the aspiration is not a tremendous amount, research shows that generally speaking, as long as patients have a strong cough, that if you just aspirate water after you clean your mouth very well, that the chances of you having a pneumonia from this are much, much, much lower than if you aspirate other types of liquids. So the point that I raise here is talk to your clinician about free water protocol or modified free water protocols, and how, if you do oral care, and how that relates to you with your respiratory stability and your cough abilities. So in conclusion, there is a lot left to learn about what speech and swallowing treatments are most beneficial for people with SMA. As you saw, there's very few studies looking at treatment for speech and swallowing in SMA specifically, but we do have some foundations from other populations that are definitely worth looking into from a research front, and you talking to your clinician about in the paucity of research. So what you may want to ask your clinician about is, what is the reason they are recommending different treatments? Don't just take it at face value. Try to better understand what is the underlying source. Is it restorative? Is it compensatory? What are their expectations from that? Feel free to talk to them about some of the studies that we have listed here. That's what they're there for. And if a clinician isn't aware of it, then that's okay, but they can certainly look into it and get more information on it. What other things you might want to talk about is how to help solve problems encountered in everyday life. So maybe your problem is difficulty not being heard and understood in certain settings. Maybe it's isolated to school or the workplace. Maybe you feel left out of certain social situations due to swallowing or speech. Make it very clear what are your goals and what are the biggest implications, because a clinician can cater what their treatment approach is based on that. I always ask my patients in sessions, what is your underlying goal? Because if your goal is to eat everything by mouth without any fatigue ever and have a steak, every meal, is that realistic? And maybe not, it depends on you, but that's something we need to know, versus I want to be able to go out on a business dinner and get through the meal without causing disturbances because I'm choking, kind of thing. Those are very different goals, and those are really helpful for the clinician to know. And also, is it appropriate if maybe ask them, should you be referred out for something if they don't know? So I think the most important thing is not all clinicians can be the best at everything. I specialize in swallowing. You wouldn't necessarily want me working you up for a full assessment of speech and language in every domain, right? So in that sense, I would gladly refer out. And so if your clinician seems like maybe he or she isn't expert in an area, then don't hesitate to ask if you have another opinion or look into other sources. And with that, we thank you and the Cure SMA community and everyone for joining us, and open it up to questions.
Great. Thank you so much, Dr. Allison and Dr. McGrattan, for a really great, very informative presentation today. We thank you both so much for your time today as well. And we appreciate everyone who joined in for today's session. There is a survey linked in the sessions page, and then you'll also be receiving a follow-up email with the survey link too, and we welcome any feedback that you have to share. And once again, we are incredibly thankful for the support from our sponsors for making the 2021 Virtual SMA Conference possible. Don't forget to join the virtual exhibit hall this afternoon from 3 to 5 p.m. Central Time to visit and see all the services and products that the companies have to share. And then you'll also be entered in to win a prize when you visit all of the booths, and that will be announced at the Friday closing session. And if there's anything that we can do for you or any additional questions we can help answer, you can always email us at familysupport@curesma.org. Have a great day, everyone, and thank you so much for joining us for the 2021 Virtual SMA Conference.